Okay, let's discuss alternatives to opiates. So we're going to try to define what ALTO is, alternative to opiates. We're going to review the common medications and treatment options in the emergency department, including following the evidence when possible, and then use some case examples at the end. So just to sort of identify the problem, this is drug overdose data for the last 20 plus years, and you can see the dramatic increase in overdose deaths to over 100,000. It is now the #1 cause of young adult deaths. And when you stratify that, the vast majority are opiates. The gray line at the top right there is synthetic opiates, and several others are opiates as well. 2 million Americans are dependent on opiates, 500,000 use heroin, probably more fentanyl now. 100 million have chronic pain, that's a little bit less than a third. $600 billion in lost productivity, healthcare expenses. So ALTO is more of a philosophy and a commitment to the idea that you're not going to use narcotics right out of the gate. Multimodal pain control is often better. And then opioids should be considered as a rescue therapy. And then there's chronic pain, which is a whole different ballgame, requiring multimodal care as well. So there's one paper I like to quote, which is from Dr. Stater at Swedish, which he implemented in ALTO in his 10 emergency departments, and then looked at data of 6 months before and after. Opioid use went down by more than a third, significant increase in use of ALTO medications, increase in pain control, improvement in pain scores, no difference in log bone fractures or cancers, no change in patient satisfaction. This slide is interesting. On the bottom, it shows you some of the different medications, and then on the top, how they work. I think rather than get lost in the pharmacokinetics here, it's more just about the idea that saturating different receptors may provide better pain relief than saturating just a single receptor, such as a mu opioid receptor or COX receptor. Hurdles can be setting expectations with patients. Most patients should understand they're not going to have zero pain. Explain why you're not using narcotics. Ask the patient if they want pain medication. That's a good skill to have in general. Avoid sedating medications. Try to determine what type of pain they have, which can drive your decision making a little bit. Visceral, neuropathic, cyclic vomiting, psychiatric. You need the department to buy in if you're going to fully commit to the ALTO concept. However, you can use it as your own individual practice if you want. And hospital buy-in is helpful as well. So how do you approach somebody with chronic pain? You just sit down and talk to them, acknowledge and emphasize you're willing to help, and then come up with a plan, which means establishing rules of engagement, what has worked in the past, why you're not using narcotics, and offer the patient a different way forward. So let's start with acetaminophen. We'll start with the easy stuff. Not known how it works, but thought to be a COX inhibitor in the CNS, not totally understood. Mostly concerned about hepatotoxicity and then some GI distress. A couple papers say that 1,000 milligrams provides more pain relief than 650, so that's your analgesic dose, 1,000 milligrams. IV Tylenol provides similar pain relief to IV hydromorphone in one paper. However, it does not reduce morphine use. Getting IV Tylenol at my shop can be kind of challenging. Similar pain relief to NSAIDs and opioids at 30 minutes. So IV Tylenol is an excellent drug. It's just getting the pharmacy to let you use it. And there's another drug called Percogesic, which I have not seen here in the US, but it's a Tylenol plus Benadryl or phenyltoxalamine. NSAIDs are mostly non-selective COX-1 and COX-2 inhibitors. There is one selective COX-2 inhibitor in the US on the market, celecoxib or Celebrex, most prescribed analgesic in the world. It has a lot of side effects, right? GI, nephrotoxic, platelet inhibition, hypertension, atherosclerotic, cardiovascular, and cerebrovascular disease, etc. These drugs are not benign. There is an association between NSAID use and increased mortality, just straight up. More NSAIDs you use, the more likely you are to die. So you want to use the safest NSAID, if we can define that, at the lowest dose and for the shortest period of time necessary. They, in general, relieve 50% of your pain after 1 week of use. And then just to comment on COX-2 inhibitors, because I'm not going to spend time on them, they increase the risk of cardiovascular disease. That includes Celebrex. Even though it's on the market, I typically don't use it for that reason. They also increase the risk of non-union compared to the non-selective NSAID. So in general, I don't use Celebrex for those two reasons. Ibuprofen, let's talk about the analgesic dose of ibuprofen. There's a couple papers that look at 4, 6, and 800, and there's just no analgesic difference between them. So as far as pain control goes, 400 milligrams is the analgesic dose of ibuprofen. You also have fewer side effects when you're giving the 400 milligram dose versus 6 and 8, so it's safer for your patients. Toradol or ketorolac, no difference between 30, 15, and 10. And really no difference between ketorolac and ibuprofen. So most of the time I'll just give ibuprofen unless the patient really wants a shot. Now, when you combine 1,000 milligrams of acetaminophen and 400 milligrams of ibuprofen, which are the analgesic doses we just discussed, right? And you compare them to Norco, or I should say hydrocodone, oxycodone, and codeine, guess what? No difference in pain for acute extremity pain, no difference for acute MSK pain at 1.5 or a half hour. And then other papers, opiates are non-superior to acetaminophen and NSAIDs for chronic lower back pain and arthritis. This one paper showed that Tylenol and ibuprofen at what I would say are the incorrect doses did not improve pain reduction in chronic back pain. IV Tylenol, IV Toradol, and IV opioids provide similar pain relief at 30 minutes. And patients who are prescribed opiates in the ED for lower back pain more likely to return at some time for the same complaint compared to acetaminophen and ibuprofen. Tramadol, okay, so tramadol is a mu agonist, therefore it is an opiate. People will tell you it's not, it is. It also has other pharmacoactivity, right? So inhibits norepinephrine and serotonin, so it has mixed pharmacokinetics, and those are widely varied between patients. Some metabolize it quickly, some do not. Some get great pain relief, some do not. Has a lot of side effects, most famously lowering seizure threshold and increasing risk of serotonin syndrome. So I basically avoid tramadol. If you want to give them narcotic, give them narcotic. If you don't, don't. But this is some kind of hybrid drug that is not really a great option. Similar to somewhat higher risk of prolonged opioid use compared with those receiving other short-acting opioids. So it still has the addictive potential of the other narcotics. Dexamethasone is a great drug. It's really kind of grown in my arsenal. Reduces postoperative pain, helps with renal colic when combined with NSAIDs. Reduces rebound migraines for up to 3 days, improves pain control when combined with Reglan. In the backs, it reduces radicular back pain at 24 hours, so that sort of acute back pain is helpful, but obviously doesn't fix any of the structural problems they may have. And then with sore throats and pharyngitis can provide pain relief in patients with sore throat. So I think there's really, unless there's a contraindication for dexamethasone, this is a great drug, and typically 4 milligrams is what these papers are using. Ketamine, I'm kind of on the fence about ketamine. People love it as an alternative to narcotics. However, as I will show you, the side effects are pretty significant. It is an NMDA receptor antagonist. The subdissociative or analgesic dose is about 0.1 to 0.3 milligrams per kilogram. You can give it IM, intranasal, or nebulized. It does provide pain relief. However, it has a lot more adverse events. So I honestly don't use ketamine that often for pain. Nitrous oxide, I don't have a lot of experience with this. I know that it's great with children, and I want to include it here because it's definitely something to be considered in your emergency department. It is a colorless gas that is an anxiolytic, analgesic, and sedative, so it's great for doing little lac repairs and things like that. Also an NMDA receptor antagonist. Rapid on, rapid off makes it convenient for the emergency department and useful for pain control and procedures in both kids and adults. There are some contraindications, including head injuries, any pulmonary disease, small bowel obstruction, pregnancy, and severe upper respiratory infections. IV lidocaine was kind of a flash in the pan for a while. The literature is not so great, but it's worth commenting on. Blocks the voltage-gated sodium channels for renal colic. You can give it at 1.5 mg per kg over 10 or 15 minutes. It's pretty safe. People kind of freak out about it, but the truth is it is safe. The data is mixed. So no benefit when compared to ketorolac alone. However, it can be seen as a rescue agent if other agents fail. And then it does not help for headache, low back pain, or abdominal pain. Antipsychotics are also an excellent choice for pain relief, as well as anxiolysis, agitation, nausea. They have other benefits as well. I typically use either haloperidol or droperidol. However, there are multiple options here. They are dopamine antagonists with some histamine, alpha-2, serotonin, and NMDA antagonism. They help with headaches, abdominal pain, especially that associated with cannabinoid hyperemesis, gastroparesis, cyclic vomiting, chronic pain. Gabapentinoids, so pregabalin and so pregabalin and gabapentin, right? So a single dose of gabapentin has been shown to have benefit in the anesthesia literature. There probably is a role for that in the emergency department. There is limited evidence for off-label use and a lot of side effects. It's on the Beers criteria. For back pain, it basically doesn't work, right? Pretty clearly doesn't work, and it has a lot of side effects. I do not prescribe it anymore. I have in the past, but after making this lecture, I just completely stopped. Muscle relaxants, probably in the same ballpark as gabapentin. Maybe you can give a single dose in the ED. Occasionally I will prescribe it, but it does have a lot of side effects and risk, and it is also on the Beers criteria. For back pain, some literature says it's better than placebo. Better literature says it's probably not. There is some pretty good literature on rib fractures, and it's specifically Robaxin, which is methocarbamol for decreased length of stay, decreased opioid use. So definitely a role for rib fractures. So I usually use Robaxin for that reason because there's some literature to support it. Lidocaine patches, typically 4 to 5% concentration. No difference between 4 or 5%. 4% is cheaper at the pharmacy in the US. You can use it for herpetic neuralgia, diabetic neuropathy, arthritis, MSK pain, low back pain. Benefit, but not superior to placebo, right? Again, a lot of these drugs are in that ballpark. Other topicals worth mentioning, there are NSAID topicals, so Voltaren, Aspercreme, ketoprofen, there's a bunch. Capsaicin is actually an excellent drug. You just have to know how to give patients a heads up. In the emergency department, probably the most well-studied use is cannabinoid hyperemesis syndrome, and it does improve symptoms, but it does not reduce. It does improve symptoms, does not reduce length of stay. It also works for back pain. Just you have to tell the patient that it's going to, burn their skin, or it's going to give them a burning sensation, right? It's rubbing hot peppers on their skin. There's also Emla cream, methyl salicylate, and then there's a bunch of compounding pharmacies, or there are compounding pharmacies that can combine a bunch of different medications, but those are typically expensive. Procedures, okay, regional anesthesia. I'm not going to talk about any specific nerve block. There are lots of upper and lower extremity ones. There's rib blocks, there's TAP, there's all kinds of stuff, but I just want to talk about them in general. Significant pain reduction alleviates the need for rescue opioid analgesia and decreases the length of stay in the emergency department. It improves patient satisfaction. And then for headaches specifically, the occipital nerve block is a great option, very effective for patients with occipital neuralgia. The sphenopalatine ganglion block, which is done through the nose, is awesome for frontal headaches, sinusitis, periorbital stuff. And then the supraorbital nerve block can be used for forehead lacerations, is also an excellent nerve block. Hematoma block, non-inferior to procedural sedation. And this is typically talking about distal radius fractures. Faster, uses less resources, shorter length of stay in the ED, right? This is a great block. I had one of my residents do a hematoma block on a proximal humerus fracture the other day, which worked really well too. So you can be open-minded about it, but generally this is distal radius fracture and thigh fractures as well, potentially. Trigger point injections are awesome if you can find a patient who has myofascial pain. What exactly do you inject? Do you do dry needling? A little bit of a question mark out there, but similar benefit to NSAIDs, lower rate of rescue therapy. I do really like this. Improved pain control, useful for headaches as well. So definitely in the right patient, this is an excellent adjunct. I wrote this as MSK injection, so it could be joint, could be bursa, and I kind of put like palpation guided, which would be probably these four: subacromial bursa, knee, AC joint, and greater trochanteric bursa are all extraordinarily easy to inject, at least in most patients, and safe to do with palpation guidance. So I would consider this as an option in the right patient for the right reason. Ultrasound guided, a little trickier, requires somebody to teach you how to do it if you aren't an ultrasound guru, but you can get in the glenohumeral joint, the elbow, wrist, hip, and ankle fairly easily once you know where to look. Non-pharmacotherapy. So ice is a big one, okay? Frequently used for acute pain, MSK injuries, evidence for lower back, neck, sports-related injuries, superior analgesia from ice compared to a cold pack. Heat. So what I usually say is use heat if there's no swelling or no acute injury. If there's any swelling or it's acute, start with ice. So back pain pretty clearly provides benefit for neck and back pain in the ED combined with other therapies. That's true of also chronic back pain. Heat therapy is an excellent option. Osteopathic manipulation, if for my osteopaths out there, there is some literature that says that it's helpful in the ED. Obviously, it's a sort of nuanced skill set, but if you are good at osteopathy, you can probably help your patients. Smoking cessation is a big one. Pretty clear literature on the relationship between tobacco use and chronic pain. Acupuncture. So these are things you could suggest as outpatient options, right? Acupuncture, mind-body therapy, yoga and Tai Chi very clearly help with core strength, muscle, lean muscle, and reducing back pain, among other conditions. Cognitive behavioral therapy, if there's a psychogenic component, massage therapy, physical therapy. All right, let's go through some cases. So a 23-year-old female presents with right ankle pain after stepping off a curb. Radiographs are normal. You diagnose an ankle sprain. So first line therapy, ibuprofen, acetaminophen, no question. Second line, if you need it, topical medications. Maybe a single dose of gabapentin. I'm not sure that I would agree with that now, but that's in this slide. And then some form of mobilization, depending on how symptomatic they are, crutches, depending on how symptomatic they are. A 46-year-old male presents with acute on chronic back pain, no red flags, radiates down right leg. So first line, ibuprofen, acetaminophen. Second line, or adjunct, depending on how you look at it, dexamethasone. So I give dex to most of my back pains with any radicular features now. Lidocaine patches, capsaicin cream. And there's a lot of stuff that you can consider. Muscle relaxants, gabapentin. Then sort of more chronically, there are a lot of medications that the chronic pain docs can use without prescribing narcotics. A 33-year-old female presents with right flank pain. She states she was diagnosed with kidney stone last week, but ran out of her medications. So renal colic, first line, Tylenol, Toradol, dexamethasone. Remember, dex plus Toradol is better than Toradol alone for renal colic. Consider lidocaine. You consider DDAVP, although the literature is not great. There are some papers that look at dicyclamine. Does not help with renal colic. A 75-year-old female presents with right shoulder pain after mechanical fall. She's diagnosed with minimally displaced humeral head fracture. So first line, NSAIDs, acetaminophen, narcotics, obviously if they're in a lot of pain, considerations, muscle relaxant, gabapentin, ketamine, NO, and then regional anesthesia or hematoma block, depending on where the fracture is. And then more chronically, there are some interesting papers on calcitonin shown to help with at least spinal fractures. A 44-year-old female presents with migraine, headache. Her Imitrex did not help. First line therapy, this is what I typically use, NSAID, Reglan or metoclopramide, and acetaminophen. I do not administer diphenhydramine. There's really no role for that. If you are worried about EPS, which is less common with Reglan, more common with compazine and other antipsychotics, put that medication in a bag of fluid and infuse it over 10 minutes, and the patient will not develop any extrapyramidal symptoms. Adjuncts that I often give up front would be magnesium and dex. Caffeine is also well studied as an excellent medication for a true migraine. Trigger point injections, occipital nerve blocks, phenylpalatine, ganglion block I've mentioned. And then antipsychotics are obviously a really good choice. Compazine is the most well studied there. Triptans, ergots, and there are antiepileptics. Do not use gabapentin, and then often sending them home on olanzapine or metoclopramide. A 21-year-old female presents with nausea, vomiting, and epigastric pain. She has diabetes and admits to smoking marijuana daily as well. So she's got chronic abdominal pain and probably or possibly cannabinoid hyperemesis. So parenteral meds here probably right if she's vomiting. So Toradol, a PPI. Often I would give her a metoclopramide or antipsychotic up front as well. Consider benzos, ketamine, more antipsychotics, bentyl. Not listed here is capsaicin cream. That should probably be on this list. Then Dr. Stater that I mentioned in the beginning, he likes an antipsychotic, IV lidocaine and gabapentin.